All right, well, welcome back everyone. So now we're going to begin looking at our next kind of major endocrine organ structure, and that being the adrenal gland, right? So first off, if you just look at the name adrenal gland, the term adrenal means above the kidney. So renal is meaning kidney, and then that prefix is meaning like above or atop or something like that. You may also see these called the suprarenal glands as well, right? So if you see adrenal, suprarenal, they're meaning the same thing. So what you see, or where you see these, where you find these in the retroperitoneal space, so meaning behind the kind of the posterior layer of parietal peritoneum, right? So in gross dissection, whenever you open up the abdominal cavity, you move aside the intestines and you move toward the back wall. You actually don't see the kidneys and you don't see the adrenal gland. You may see kind of their impression, their outline, but they're covered by that layer of parietal peritoneum that needs to be removed. And then surrounding the kidney and the adrenal gland is a lot of connective tissue, right? Lots of fat around the kidney. It's called perirenal fat, and the adrenal gland itself in dissection can sometimes be difficult to identify because it is kind of lost sometimes among all the fat tissue, right? All that connective tissue. Regarding the adrenal gland itself, there are two kind of internal layers or regions, one called the medulla, which is the deep inner layer that produces our catecholamines, epinephrine and norepinephrine. And then there's an outer layer that is called the cortex, and this is producing steroid hormones. It's going to produce things like aldosterone, cortisol, things like that. And then there's sublayers within that. So within the cortex, there's what's called the zona glomerulosa, the zona fasciculata, and the zona reticularis. And we'll look at each of those in just a moment. So here's some gross anatomy of the kidney and of the again focusing specifically on the adrenal gland. So here we see our inferior vena cava. Right here we see an aorta right next to it. We see the veins coming off into the kidney, and then sitting right above the kidney, we can see this kind of triangular shaped, pyramidal shaped adrenal gland, right? Again, sitting right atop the kidney. If you were to take a section of the adrenal gland, this would be something close to what you would see. You'd see well, you wouldn't see, it wouldn't be this visible, right? It wouldn't be this obvious, right? But you can imagine you'd see these various layers. You see the cortex, which anytime you see the term cortex, that's meaning outermost, and then medulla is meaning innermost, right? Within the middle, right? So think medulla middle. So you can see here, you can see your cortex all out here, and then here in the middle, you have your medulla, and then you have this connective tissue capsule that surrounds it, and then even outside the capsule, you would have additional fat. And then, of course, you'd have that layer of parietal peritoneum as well, right? So here's our cortex. We can see our three kind of sub-layers or zones within it. So the zona means zone. So we have a zona glomerulosa, zona fasciculata, and zona reticularis, right? And again, we'll talk about what hormones are coming from each of those. And then deep within the tissue, deep within the adrenal gland tissue, we see our medulla, right? So again, glomerulosa, fasciculata, the largest layer, reticularis, and then we see our medulla deep within, right? So whenever you're looking at the histology of the adrenal gland, one helpful tip is to try to identify where the cortex is, right, and where maybe the outermost layer is, and then maybe work your way down. Right. So in other words, if you can find the cortex and you can find which layer is most superficial, right, closest to the capsule, then you know that's the glomerulosa. And then going down, you have glomerulosa, fasciculata, reticularis, and then you move into the medulla, right? So that'll help you kind of identify some of the layers, right? So here we see a section of the histology of the adrenal gland, and again, what I just said, try to find the outermost layer, right? So we know that all of this out here, this is the outer aspect of the tissue, all this white space. So that means this here, this is the capsule, right? And all the connective tissue, so you can see lots of fat around it here. So here's our capsule. And then we have three layers. We have a glomerulosa, we have a fasciculata, and then we have this reticularis. And you can kind of trace these around the corner. And then deep in here, we have the medulla, right? So capsule, zona glomerulosa, zona fasciculata, zona reticularis, and then we have our medulla way in here, right? So what's coming from each of these layers, right? So from our zona glomerulosa, we have mineralocorticoids, right? These are helping to regulate ion and electrolyte levels, primarily sodium and potassium, and the main one that we're focused on, or that we will focus on, is aldosterone. Right, aldosterone. When you think of aldosterone, it is acting to promote the reabsorption of sodium and thus water, and at the same time excrete or get rid of potassium. Right, so sodium and potassium will have an inverse relationship. The zona fasciculata, that middle layer of the cortex, that largest middle layer of the cortex, is going to produce what are called glucocorticoids, and so this is cortisol, right? And so this is, sometimes you may think of it as a stress hormone. It is also regulating blood sugar as well, right? So that's where we get the term glucocorticoids, right? And then we have our gonatocorticoids producing our sex hormones, right? So this is the zona reticularis, that deepest layer of the cortex right next to the medulla, and these are producing androgens, right? And androgens are male sex hormones, or hormones that promote the development of male secondary sex characteristics, right? And in females, these androgens will get converted into estrogens. So an important note here is that for these androgens, they're actually made in several places. Like one, they can be made in the adrenal gland, right, in this zona reticularis, but for males, they can also be made in the testes, right? We can make testosterone in the testes, and so in that case, you have sex hormones coming from two different location, right? So the amount produced by adrenal glands is less than that from the testes. So in males, the testicles produce the majority of the androgens, of the testosterone. So when we're thinking about the release of these different tissues, right, there are various stimuli. If we're talking about our glucocorticoids, so things like cortisol, these can be released in response to an illness, stress, damaged tissue, right? And then the actual mechanism is through a similar axis to what we talked about earlier, right? So we talked about the axis that kind of controls the release of things from the thyroid gland, right? You have a similar one, but in this case, with the adrenal gland, right? So the hypothalamic pituitary adrenal axis. So something from the hypothalamus, which is CRH, remember, corticotropin releasing hormone. Remember, you know it's from the hypothalamus because it's called a releasing hormone. So CRH from the hypothalamus stimulates the release of ACTH. Okay, ACTH is adrenocorticotropic hormone. ACTH, that's from the anterior pituitary, right? And then ACTH stimulates the release of our glucocorticoids, right? Our cortisol, corticosterone from our zona fasciculata, right? From our zona fasciculata. And so these will bind onto carrier proteins. They will travel around in the bloodstream. They will bind onto their target cell receptors, and then, of course, they're regulated via negative feedback, right? So if we look at a similar image to what we looked at earlier, you can see kind of the pathway that our various hormones, corticotropin hormone, releasing hormone, ACTH, and cortisol, the pathway that they'll take on their way to their effectors, right? So maybe stress, something like that, blood sugar levels, maybe time of day stress, will release corticotropin releasing hormone. This will stimulate the anterior pituitary to release ACTH, right? So here we are in here, right? So releasing ACTH. ACTH is going to travel down to the adrenal glands and stimulate the release of cortisol, right? So here with number 6, and these are the various effectors, right? So increased glycogenolysis, decreased glycogenesis, increased lipolysis, stimulation of protein catabolism, so breaking down proteins to be used for maybe cellular respiration, right? To be used for making energy, right? And then high levels of cortisol we can see are helping to retain sodium and water, decrease inflammation, suppress the immune system, right? And inhibit connective tissue repair. So this is the reason why when you are ill, right, you may be sick, you have some illness or something, you may be prescribed a steroid, right? And you take that medication, and we'll talk about that here in just a little bit, right? And so we're increasing nutrient levels in the blood like we've done with some other hormones as well, right? Thyroid hormone, growth hormone. And then this is controlled via negative feedback, right? So remember, most hormonal pathways in their secretion and production and release are going to be governed by negative feedback mechanisms. So here you can see some variation in cortisol, right? So it is also, it will vary based on time of day, stress as well, right? So increased levels of stress will promote the release of our glucocorticoids, our cortisol. So you can see that pretty clearly here. And then what I was mentioning earlier in terms of taking steroids, right, for an illness or something. So you'll notice here with this image, again, they're taken for inflammation, suppressing the immune system. Now, when you are prescribed a package of medication that's a steroid for an illness, right? You will essentially always see them as a tapered dose, right? So meaning on the first day you take this many, the next day you take a few less, the next day you take a few less, until you've only taken one and then you're done, right? So if you look at this one, this is methylprednisolone, which is it's a pharmaceutical. It's a drug, right, that you may get prescribed from your doctor. You pick it up at a pharmacy, and you'll notice that this is a 6-day sequence, right? So you can see here that the first day we're taking 6 tablets, right? It says 2 tablets before breakfast, 1 tablet after lunch and supper, and then 2 tablets before bedtime. So 6 throughout the day, right? And you can see that these are 4 milligram tablets. So you take 6, right? The second day you take 1 at breakfast, 1 after lunch and supper, and then 2 tablets before bedtime. So now we're down to 5, and then 4, 3, 2, and then by the last day you're only taking 1, right? So think about why it is that we taper our dosage for steroids, right? So in other words, why are you decreasing the amount of steroid that you take each day, right? Well, if you think about it, you are taking something that your body naturally produces. Right? Your body naturally makes steroids, right? So if you take some level of steroid, right, exogenously, right, as a medication, you consume it, and your body does not produce it, then that is in some way affecting the negative feedback mechanism on the adrenal gland, right? So it may be telling the adrenal gland, hey, we have enough steroid, don't make any more, right? So if you continue to take steroids at a certain dose, right? So maybe you took 6 tablets every day for 6 or 7 days, and then you stopped, right? Well, that level of cortisol in the blood from your medication has now kind of, you can think of it as almost suppressing the adrenal gland to not produce any, right? So at the end of your 6 or 7 days, if you've been taking 6 tablets every day and then you just stop, well, now you're not taking it as the medication, but your adrenal gland has also gotten used to not producing it, right? So you don't have sufficient amounts of steroid, right? So by tapering your dose, what you end up with is you gradually allow the adrenal gland to replace some of that cortisol that you're no longer getting from your medication, right? And so by the time you are only taking 1 tablet, your adrenal gland is producing the majority of the cortisol that you would need, right? So that's why you are tapering your steroid doses, right? So there's various other disorders that would require you to look at the levels of steroids in the body. So one of these is Cushing syndrome, right? And this is too much glucocorticoid. This is too much cortisol, right? So excessive glucocorticoid hormones in people taking corticosteroids for therapy, right? So some issues with this: obesity, hypertension, right? If you look back at it, at high doses, it's increasing the retention of sodium and water, right? And so you can end up with hypertension, obesity. You can end up with retaining a lot of this fluid, right? So ending up with high blood pressure. You can also get something called hirsutism, which is this excessive male pattern hair growth, often in females. You can end up with kidney stones, and you can also have menstrual irregularities as well. Addison's disease is basically the opposite of Cushing's syndrome. So you end up with a deficient or an insufficient amount of cortisol from the adrenal glands. So when your adrenal glands are failing, chronic shortage of glucocorticoids and sometimes even mineralocorticoids, so like aldosterone, that we'll discuss more. It may be an issue because of some other kind of upstream problem, right? So maybe something with ACTH, right? Remember, ACTH is from our anterior pituitary, right? Adrenocorticotropic hormone. So if you don't have enough ACTH, then you're not stimulating enough release of cortisol in the adrenal glands, right? So weight loss instead of obesity, you may have fatigue and weakness, hypotension instead of hypertension, and you can also end up with skin darkening as well, right? And you may treat this by taking oral corticosteroids, right? So you take medications to replace the steroids that you are lacking, right? So with regards to this discussion of cortisol and how it's involved with the stress, stress can elicit it, right? There's something called the stress response, right? And the stress response is this response we have to some given stimulus or some stressful stimulus in our environment. There's these three main stages: the alarm reaction, the resistance phase or stage, and then the exhaustion stage, right? So in this initial alarm reaction, it's mainly nervous system, right? Sympathetic nervous system activates, epinephrine, norepinephrine are released, right? So think back to autonomic nervous system. What do epinephrine and norepinephrine do? They are increasing things like heart rate, blood pressure, respiratory rate. They're decreasing the rate of digestive processes, things like that, right? So this is this initial reaction, right? Resistance is a period afterwards in which we've depleted glycogen stores, so we're mobilizing nutrient reserves, right? So we're breaking down glycogen into glucose. The adrenal gland is secreting cortisol to help raise blood sugar, and then that sugar is being used to meet energy demands, right? So maybe making ATP so you can contract your muscles, so you can deal with whatever the stressor is that you are dealing with, right? And then if you're in a chronic state of stress, this stage of exhaustion after weeks and or months, you can deplete many of your nutrient stores, right? So breakdown of fats, turning into the breakdown of protein as well. So you essentially begin to catabolize and use your own body's muscles for energy, which contributes to weakness, which contributes to illness, which contributes to chronic illnesses, right? So alarm reaction, resistance, and then our exhaustion stage as well, right? So consider some of these questions. We will stop here, and then we will pick up in our next part, and we'll look at the pancreas.